All right. Hello, everyone. And we're going to go ahead and get started so we can begin and finish on time. Welcome to another session of the Virtual Global Spine Conference. It's a pleasure to have you with us, either in live now or for those of you who will be seeing the recorded session later on our online channel. It's a pleasure to be here. My name is Ali Baaj. I'm a neurosurgeon at the University of Arizona in Phoenix. And I'm delighted to be speaking today and sharing some thoughts on a really important topic, I feel, in spine surgery, certainly in modern spine surgery. I think it's an important topic for those of us who either do minimally invasive spine surgery or maybe who don't, but are just interested in learning a little bit more about it. And really, my goal is to give an unbiased view about it on this topic, and I really feel I'm personally in a good position to do this because I don't necessarily have any specific conflicts one way or the other. I'm primarily an adult adolescent spine surgeon. The focus of my practice is degen, complex degen, deformity with some oncology and trauma. I use both traditional open techniques as well as less invasive techniques or so-called MIS techniques on certain occasions. And I'll just share with you my thoughts on this topic and certainly my journey over the last nearly 15 years into practice and what the pros and cons are, and hopefully a little bit about what the future holds. Like I said, probably I feel that I'm well positioned to discuss this because I really don't have any conflicts with actual devices or actual procedures. I do teach a lot, as some of you know, and I have some publications out, but I don't have any specific conflicts with minimally invasive instruments or devices. Some of you have seen some of these slides, so I apologize if it's a repetition for some of you. For those who are new to our program or perhaps have not seen some of these slides before, I hope you find them helpful. So I always like to start with this slide when I talk about minimally invasive spine surgery, because the picture on the left is a two-level minimally. These are both my procedures, so I did these a while back. The picture on the left is a two-level MIS TLIF. The picture on the right is a one-level open TLIF. I do like a lot of posterior-based surgery, so I do a lot of posterior inner body fusions. And so the first really take-home point is, this was early in my practice, and when I do the MIS TLIF, say on the left side, I was very proud of my work. I was very happy with it. Minimal blood loss, quick recovery, et cetera, et cetera. But then I realized, like others, that it's not just about the incision. It's not just about the less invasive nature of the procedure, because when I look back at this now, 5, 6, 7, 10 years later, now that I've been performing both open and MIS procedures for over 10 years, I'm really more happy with the open TLIF picture than the MIS picture. And that's because we weren't really taking a lot of the deformity parameters into consideration. The lordosis, the focal lordosis, the segmental lordosis. And today, my MIS TLIFs have gotten a lot better. They've gotten a lot better because now I have a better appreciation of really the lumbar and the lumbopelvic deformity parameters. So point number one here, is, offering a minimally invasive solution or minimally invasive, especially fusion procedure, is not an excuse for not doing the proper surgery under the proper indication with the proper biomechanics. So that's a very important point. And again, we all start and navigate in this journey where we're just happy to be able to put in a screw percutaneously or put a TLIF cage or a lateral cage or whatever it is with a small incision. Okay, that's fine. After the initial excitement wanes, we have to be, we have to be a little bit more judicious about, let's not forget the principles, of course, of spine surgery. So in effect, if I do this MIS TLIF surgery today, I would not be happy with that X-ray. I would do a better job at, facetectomies, lordosis, either expandable cage or not, or maybe do an ALIF with perc screws. That's probably even a better procedure to provide lordosis than a 1-level or a 2-level MIS TLIF. That's for a different topic. We talk a lot about ALIF and TLIF in this program, but that's lesson number 1, or that's take-home point number 1. We all know now, after all these years, MIS surgery is not really about a tube or a robot, or about a small incision. It's really more of an approach. For a lot of the folks here, and Dr. Selby, one of our co-hosts, is here, who's a really good both open and MIS surgeon. I see a lot of folks here I recognize in the chat. But, for us, it's very simple, right? A big open T10 to pelvis or a T4 to pelvis, that's considered open surgery. That's not minimally invasive surgery. Now, on the opposite spectrum, let's say an ALIF, 2-3 level laterals, and then posterior percutaneous screws. In some ways, that's considered MIS, but we'll talk about why those 3 procedures together, or the morbidity of 3 approaches, may be equal or greater than 1 open approach. So we also have to take that into consideration. This is one of my favorite videos. You guys have all seen this before. This is a tubular laminectomy. You see nice ligamentum flavum resection. You see nice pulsation of the CSF. The dura is intact. I didn't show you the CSF leak. That's a different case. But this case went really well. But this is what we consider MIS, right? When we drop a tube and we're able to do a nice laminectomy and get away with a really nice decompression. Now, if you look up minimally invasive spine surgery on Google, this is what you're going to see. You're going to see a lot of tubes and retractors and expandable retractors and tubular retractors and endoscopic instruments. So that's really what it is. But everybody knows that MIS means different to everybody else. When I talk to a patient in clinic about doing, say, an open 1-level laminectomy, right? Everybody here does it. Open 1-level laminectomy with a McCullough retractor or maybe a small Taylor retractor. That's a very minimally invasive surgery. Just because I didn't use a tube, that doesn't mean it's an extensive operation. So MIS is not about instrument or tubes or retractors. It's really about the extent of subfascial dissection. T10 to pelvis, that open, that's a big dissection, big approach. 1-level or 2-level lami, even if it's done open, I really do think that's a minimally invasive operation that's actually quite effective. Now, we have to be, I call it being intellectually honest. We have to be intellectually honest with our trainees, with our patients. There are definitely advantages of MIS. We all know them: small incision, minimal blood loss. Probably the number 1 difference maker here is less infections. There's absolutely no question that with MIS TLIF, with ALIF, with MIS lamis, perc screws, you get less infections than an open procedure. No question about that. But the real question is, at 2 years and 3 years and 4 years, are the outcomes the same? The jury's still out on that. So we have to make sure we can counsel patients appropriately when we talk about the pros and benefits. Now, the title of this talk is Truths, Myths, or Facts, Myths, and Realities. Well, here's a reality. Okay, this is a reality. There are real obstacles to minimally invasive spine surgery, and that's why I would probably venture to guess that 80 to 85% of surgeons in the world probably do not do any MIS surgery. That's a big percentage. But most surgeons around the planet are not doing MIS surgery because here's a reality. It's technically demanding. You've got to spend time learning and retraining yourself, training others on how to do it. The costs are high. The costs of robotics, of percutaneous instrumentation, implants, and endoscopy tools, they're not inexpensive, and not every health center, not every hospital in America or outside of America or in Europe or South America or Africa, wherever you want, the costs can be prohibitive. And finally, for somebody to say, well, hey, we're going to spend all this money, we're going to spend all of this training and technically demanding, and you're telling me that the equivalence is about the same. This is a reality. We have to overcome these obstacles. And we also have to answer these two questions, right? We have a lot of senior colleagues, senior surgeons who always say, we've always done it this way and it has worked. Alternatives have always worked. Why are we reinventing the wheel? Why am I going to change what I do? The reality is because that's how we push innovation. That's how we push science. I saw online the other day a chairman of a neurosurgical program said this very nicely. He said that if I'm practicing the same way I learned in residency, then there's a problem. I've lost already. And I fully agree with that. If I'm doing the same thing today that I was doing 10 years ago or 15 years ago, just because it works, that's not enough. I have to make it better. So that is a reality. I put this up here just for 2 minutes because this was brand new. This was yesterday and circulated around the news and social media and all of that. You take a look at a very, very good robot, right? Very good robot like the Globus robot that has a very good footprint in the US and outside of the US. And now there's a whole buzz about the FDA saying, well, there was some issues or maybe the way they managed their quality checks or their complaints. I really don't know the whole story, but what I do know is from what I read is the expectation is, well, hey, why isn't this robot 100% accurate? Why aren't the screws 100% accurate? And it made me think. I was thinking about this actually, and I don't use a Globus robot, by the way. We don't have that at our center. I wish we did, but we don't have that. But I was thinking about robotics technology, and I was thinking, it's funny how our healthcare system works and how our culture works. A lot of spine surgeons do pedicle screws left and right every day. Some freehand, some fluoroscopic based, and yeah, some of them they're inaccurate, right? I mean, sometimes they're takebacks for revisions. That seems to be more acceptable than a robot assisted, pedicle screw placement if that goes awry. In other words, the standards are not the same. We do expect these technological advancements like robot-assisted, nav-assisted screw placement to be more accurate than freehand. We expect it, and if it's not, yes, it's not going to be held at the same standard. We're going to scrutinize new technology more than the standard because that's right. That's exactly why these devices cost millions of dollars. They're going to be held at a different standard. So I just want to point that out there to realize that, again, the topic of this talk, facts, myths, realities. So here's another reality. We hold the technological innovations to a higher standard than the traditional, less technologically based approaches. That's a reality that we medical device companies, engineers have to understand and embrace. Radiation exposure is a big deal in minimally invasive spine surgery, especially with fluoroscopy-based type of procedures. I know when I was initially doing a lot of laterals, and I'm sure a lot of colleagues here who do laterals probably are still doing a lot of fluoro-based surgery, and that radiation accumulates. And that's a fact. We have to be able to mitigate that and decrease that. And I think navigation and CT-based solutions are improving that. Now, this is a general review for maybe some of our trainees or medical students that are joining us today. There are many different types of minimally invasive spine procedures, certainly endoscopy, tubular microdiscs, percutaneous pedicle screws. I personally think that, and I don't mean basic to mean that they're easy to do. That's not necessarily that they're easy to do, but if we categorize the different types of minimally invasive procedures, I would say that at least in the US, we would like our trainees, our neurosurgery spine trainees, orthopedic spine trainees, and fellows, let's say, to really have a good understanding of basic and intermediate type of MIS. You may not be an MIS surgeon one day. Your practice may shift in different ways, but I really hope that every single resident graduates knowing how to put in percutaneous pedicle screws, know how to do a tubular laminectomy, perhaps a lateral case, definitely a the ALIF approach, which is the most MIS effective procedure out there. So we do have to integrate that more into our training so that the trainees have exposure to these minimally invasive approaches. And, this is one of my patients from years ago that needed a discectomy, morbidly obese, heavy patient. Could I do this in an open fashion? Yeah, of course I can do it in an open fashion, but a small tubular case makes this case safer. So there are instances where less invasive tubes, retractors, give you better options for you and for your patient, and I'm going to demonstrate a couple of cases like that to come. Again, you've all seen this before. I've put this out online several times. But these a microdiscectomy, right? One of the simplest procedures. It's a great tubular case, And I have always colleagues that say, well, is a tube easier? Is a tube better than a mini open retractor or open, type of retractor? No, it's not. But a tube is a great retractor for soft tissue circumferentially. So in bigger patients, the tube is actually the best retractor because it retracts circumferentially. Now, a word to some junior colleagues and definitely those in trainees. I think a lot of folks can get into this idea in which it's a competitive market, right? Especially if you're in a competitive area, city, state, country. You want to differentiate yourself. When you finish training, you want to be the robotic surgeon, the MIS surgeon, et cetera, et cetera. And I've always felt that that's the wrong question, right? It's the wrong question. It's the wrong approach to say, hey, I'm going to be the next endoscopic spine surgeon in town. How about this? Why don't we kind of turn this into a good question or a correct question, which is, how do I achieve proper decompression, prior arthrodesis, realignment, stabilization and fusion with the least amount of collateral damage? And now you can incorporate endoscopy and tubes and retractors. I always tell folks, try to be dogmatic about the principles, not necessarily the technology, because technologies are going to come and go. If all you are is the robotic surgeon, well, what's going to happen in 10 years when there's augmented reality, virtual reality? You're going to be squeezed out. So stay nimble. Stay flexible, try to be adapting, if you will, be able to adopt new technology. But you can only do that if you don't lose sight of the principles and techniques of spine surgery. The technology and all of those bells and whistles all make it a lot prettier and nicer and fun and energizing and innovative. But the focal point are the foundational principles and techniques of spine surgery. I've shown this before. This is a case that I show often because it really shows how less surgery is not always better. This is actually a type C, AO type C fracture that somebody treated with a short segment fixation, circumferentially, by the way, less invasive, corpectomy from the sides, short segment fusion from behind, and it failed within weeks. Literally within 2 to 3 weeks, it failed. You can see the staples are still in there. Less surgery is not always better. You have to respect the biomechanics and the deformity principles, including trauma deformity principles, so that you do the correct operation. We ended up salvaging this and extending this slightly above and slightly below, and had a very, very good outcome. My personal journey with less invasive surgery, I started learning MIS TLIF really the hard way with two C-arms, a lot of fluoro. I was wearing lead, I was wearing loops, and I'm very lucky. And this is how I used to do it. Everybody has a different style, right? I used to put wires in and then do the TLIF and then put in the screws later. I'm really happy. I'm excited to say that I have not used a K-wire probably in about 10 years. I have not used a single K-wire in 10 years. I probably have not put in a fluoroscopic-based perc screw in nearly the same amount of time because now it's all navigated. It's all CT-guided navigation. This is my current setup for perc screws or for TLIFs or any posterior-based minimally invasive procedure. And even complex cases like abscesses, like vertebrectomies, like corpectomies. Like in this case, this is a transpedicular decompression for abscess. Again, put all the MIS tubes, hats on. You know how to use a tube. you know how to put percutaneous fixation with navigation. And this patient did absolutely great with resolution of that infection without having to do a vertebrectomy or a two-level corpectomy. I'm not saying you don't need to do that sometime, but what I'm saying is being open-minded about less invasive techniques and approaches gives you more options. It gives you more options to do complex surgeries. And again, and I'm not advocating for one company over the other, but this is nowadays how I put basically all my percutaneous screws. They're all navigated. I don't wear lead. I don't use fluoro. There are no K wires. It's a really nice way to do these. And you know, everybody shows these small incisions. But like I said before, it's really not about the incision. It's what happens under the fascia. What happens below the fascia, to me, dictates whether this should be considered minimally invasive spine case or not. My earlier MIS TLIFs, again, I'm not too proud to mention that, you know, at that time I thought they were great. Today, when I look at them, I critique them very harshly and I say, this is terrible. I didn't restore lordosis. I didn't take into account PI lumbar lordosis. It's not enough, you know, spine degen surgery, especially degen surgery, is not screws, rods, and cages. It's decompression, realignment, stabilization. You see the difference? So now we're obviously a lot better at this as we're understanding how to perform these cases using the appropriate techniques. These are what the TLIFs looked like now. Nice disc height restoration, nice lordosis. When I look at this, I'm much happier than I was with my TLIFs, especially my MIS TLIFs years ago. A couple of points again about minimally invasive spine. I think trauma, tumor, and I put this online a few days ago, trauma probably, and oncology. Trauma and oncology are two areas in which less invasive surgery has really revolutionized those topics and those fields. Very quick percutaneous stabilizations, minimal approaches for fusions, getting patients on and off the table quickly, getting patients to you know, to rehab or to you know, chemotherapy or systemic therapy. Get them off the table. Less anesthesia, less soft tissue damage is better for these patients. So I think MIS surgery has been great for that. 2 or 3 slides very quickly about the lateral approach. You know, everybody knows that the lateral approach is very, very powerful in cases of scoliosis, even trauma and tumor. We published quite a bit back due to I was fortunate to have trained in a program where Dr. Uribe was there, who was really one of the pioneers in laterals. I probably do a lot of more posterior approaches than laterals. Please don't tell him I said that. But that's just the way it is. That's my practice. But again, a great solution and a great option for some of these pathologies. Again, MIS is excellent for trauma. It's absolutely excellent for oncology. And getting back to the theme, again, facts, myths, and realities. One of the facts is that you can do more with MIS for complex cases, right? A lot of people are like, no, complex cases, you need a big open incision. That's actually not true. So, you know, actually it's a myth, right? One of the myths of MIS, you can't do big surgeries. That is very not true. You can do big surgeries with MIS procedures and MIS techniques, like this terrible, terrible infection, osteodiscitis, that we did not want to open the whole back or certainly go through the front. This was all percutaneous debridement, percutaneous TLIF style debridement of the disc, percutaneous stabilization, and the patient did absolutely great. I don't know if I have their MRI. No, I don't. But I have an MRI pre-op in 3 months with excellent resolution of the infection and a much better, much more room in the canal. All percutaneous stabilization, decompression. So yes, it is possible to do quote unquote bigger surgeries with less invasive techniques. Again, as I mentioned, I think tumor and really oncology and trauma are 2 huge applications for MIS. I really would recommend colleagues look into that a little bit more and at least consider that for those types of cases, getting patients in and out of the bed quickly, in and out of the OR quickly. A word on navigation, because I'm a huge fan of navigation. I've converted into CT guided navigation probably about what, 8-9 years ago, thanks to Roger Hartle up in New York, who basically, told me you have to do everything navigation, and I was like, why? We can do it freehand. And very quickly I realized, like, yeah, navigation is very nice. So I have to thank him for that. But you have to also know the anatomy. You have to know how to operate so you can use navigation successfully. And this is found online. The one on the right, it was in a newsletter for the spine section. There are 3 or 4 points about navigation, right? You can't just bring it, or robotics for that matter. You can't just bring it in for the complex cases. You'll get in trouble. You want to bring it in for every case. You want to bring it in for the easy cases, so you know the limitations and the strengths when you want to use it for the tougher cases. And this is another surgeon who did this operation, a C1 C2 fusion, using navigation, and this is the result. So navigation is not going to do the surgery for you. We're excited about launching our own robotics program here at Banner University a little bit over a year ago. We're in the early phase of adopting this technology. And I tell everybody, hey, does it make you go faster? No, it slows me down. Does it impede your workflow? Yes, it impedes my workflow. It's a pain in the butt. Well, why are you using it? Because I have full faith, and I really do believe that in 3, 4, 5, maybe 10 years, this technology is going to be a game changer. And I don't want to learn it then. I want to learn it now. Now, we're doing this surgery safely on our patients. We're not trialing this on our patients, but it is slowing us down a little bit in terms of the robotics technology. But this is an investment for later. Okay, this is an upstream investment for much later. So we're really excited about that, training our fellows and trainees with some early experience with robotic assisted technology. In the last 2 minutes, just real quick, there are some big cases, right? There's some big cases that you just have to do big surgeries on, whether it's a fixed sagittal deformity that needs PSOs or VCRs. And I tell my colleagues and my fellows, don't undercorrect just to use MIS. If you're not sure how to get the result you want, don't do MIS and say, well, somebody else later will revise it. It's better not to do anything to the spine than do something to the spine and fuse it in deformity, right? So the first time is usually the best time for a good outcome in spine surgery. I think scoliosis, I think we still got ways to go in terms of MIS solutions for big scoliosis surgeries. And again, that's a different topic, that there are people who are better equipped to talk about this than I am. But certainly things like PJK, PSOs, VCRs. I mean, you really do need an open approach for these, in my opinion, nowadays. And I hope that does change in the future. So back to what can and can't be done. Discs and lames, spondies, perc trauma, perc tumor. Those are great MIS cases. I do think that PJK, PJF, severe imbalances, whether it's a fixed coronal and sagittal deformity, is a big problem. And I think, we're still trying to understand whether this hybrid MIS is really MIS. You do a 2 or 3 level A-lift, 2 or 3 level lateral, and then you go posterior. Is the combination of these 3 approaches really still minimally invasive or not? The verdict is out on that, and that's a hot and popular topic in conferences, and we'll leave that for another time. So here's a conclusion. Here's a summary slide. I think as far as facts, I think minimally invasive spine surgery is popular. I think it is marketable, and I think it makes sense. And there's nothing wrong with saying I use or I advocate a technique or a solution that's popular and marketable. Nothing wrong with that. Now, it's going to replace open surgery? Never. It's not going to replace open surgery. It just can't. And there's no reason to. It complements. It doesn't replace. It complements open surgery. And here's the reality, especially for the young folks. My recommendation is learn it, use it. Keep it part of your toolbox and your armamentarium. That way, if things come by in the future that are less invasive, that perhaps you like more than now, you can engage with those much easier and quicker. You know how to work in a tube. You know how to do microscopic surgery. You know how to use instruments in small, narrow corridors. That makes you a better surgeon. I think it's a great addition to the toolbox. And yes, patients do ask for it. You know, patients ask for minimally invasive spine. They ask for endoscopy. They ask for lasers. And of course, we have to educate them and say, listen, we have to do the right thing. But a lot of this can be driven by the market, driven by patients, driven by media. And it's okay if we kind of keep up with it, as long as we're sure that we're providing safe and effective surgery. So I appreciate everybody's attention here. This was meant to be a short talk, a 30-minute presentation. I'm happy to take any questions on the chat. Let me see where the chat is. Dr. Selby says, I think the laminectomy has to spare the spinous process in some way to be MIS, aiming to preserve the soft tissue envelope. I think you're absolutely right, right? And there's no better example than doing a decompression above a fusion, right? How many times have you all seen this? Somebody's fused L3 to sacrum or L4 to sacrum, and they have adjacent segment stenosis, no spondy, no deformity. And if you open a textbook, the textbook says laminectomy, extend the fusion, right? Or maybe a lateral fusion, or maybe an ALIF or lateral. But the reality is, like Dr. Selby was referring to, if you're able to spare the facet joints, if you're able to spare the posterior tension band, the interspinous ligament, the supraspinous ligament, and perhaps go through either a mini open approach or a tubular approach, like I showed in one of the slides, you can get a really good decompression and sparing a lot of the stabilizing structures. So I do think MIS has probably decreased the number or the need to extend fusions, as opposed to doing adjacent segment laminectomies alone in the correct context. Another question here is from Leonardo, Dr. Soto. For the practice of minimally invasive surgery, what I have learned in residency, the practice in cadaveric laboratory for better precision. Absolutely. The cadaver lab is, you know, I tell everybody, the cadaver lab is the test tube of spine surgery, right? Our test tube as spine surgeons is actually the cadaver lab, the anatomy lab, where you go and trial this. And so what I tell folks is, yes, start with reading the technique, do a lab, and a lot of the vendors and industry partners today, they all have different, you know, very nice anatomy labs and cadaver-based labs really throughout the world. Go visit somebody, you know, visit another surgeon who's doing a specific procedure that you like. And if you need to, sometimes you need to do a mini fellowship, like a 3-month fellowship or a 6-month fellowship. But at the end of the day, you've got to get your hands on it. You've got to do the procedures. And yes, you know, my first MIS TLIF was 8 hours. 8 hours. I'm embarrassed to say that. Now it's an hour and a half. But you have to be safe, right? So in the beginning, when you learn a new procedure, it's going to take you more time. Your partners are going to, you know, laugh at you. The anesthesiologist is going to get upset. Nobody likes it. But you're investing in the future of your own skill set, and you're investing in the future of what you can provide for patients down the road. And it's very, very well worth it. You just have to accept that initial discomfort. As they say, you have to be comfortable with being uncomfortable for a short period of time until you get over the learning curve. As Dr. Selby said, AO Spine does great short-term visiting fellowships. Feel free to email us or contact us. In fact, a lot of the faculty on this program, like Dr. Selby, myself, and others, have visitation programs. But I think it's a great topic, and one we will keep discussing on this platform on Virtual Spine. So without further ado, I would like to thank everybody. I do have to get back here and to finish the day in the operating room. But this was a great session. Thank you for giving me the opportunity to share my thoughts. And we'll see everybody next Thursday, every Thursday on this program on Virtual Spine with a new speaker next week. Thanks, everyone, and have a great night.